This year, the Hypertrophic Cardiomyopathy Association marks 30 years of connecting patients to expert care. During that time, HCMA has recognized more than 60 centers of excellence across the United States. These programs use a multidisciplinary team approach to help you manage life with HCM with access to the latest diagnostics and treatments. One patient says his center helped him finally feel heard and confident in his care. To learn more, visit the HCMA website and use the Centers of Excellence directory to find the right program for you and your family.
Start this podcast with a good morning, but it's a good afternoon. It is January 30th, which means we are on the precipice of Heart Month. And this year, February is kind of a bigger deal than normal to the HCMA, as it officially rings in our 30th year of operation. And during that 30 years, we've done so much work with so many of you. It's just absolutely amazing to think I've been doing this for 30 years because I don't feel 30. How can I be 30 years old and be doing this 30 years? So it's a big day here. It's going to be a big month. So it is also the eve of my transplant anniversary. It'll be 9 years on February 2nd, which is also Groundhog's Day. And there's going to be, we're going to be holding a webinar, announcing a new law in Minnesota or new bill in Minnesota. And it is going to be presented on the 2nd by a state senator who is a member of the big-hearted community. So we are literally everywhere, including the state houses. So come join us on the 2nd to hear from a Minnesota state senator who is a member of our club and going to assist us in finding more people with HCM through the Children's Cardiac Safety Act becoming law. This edition of Tales from the Heart is our publications section, I guess we're going to call it now. And what we've been doing is we've been looking around recently published articles for things we think are important for the community to understand, but directly from the researchers themselves and those who published. And this is not an industry-sponsored study. This is a Cleveland Clinic, let's look at our data type study. And I've asked Dr. Milind Desai to come and talk to us about 2 articles. One is entitled Characteristics of Long-Term Outcomes of Asymptomatic Patients with HCM. But are they asymptomatic? That's kind of the question and the tease. And then there's a follow-up research letter on treadmill stress tests in HCM. So we have some really interesting articles to discuss. We will welcome your questions after we get into this a little bit more. Milind, thank you so much for joining us today. And let's talk a little bit about this article that was published late last year.
Yeah, thank you, Lisa, for having me here. And yes, I am excited to talk about these 2 very relevant articles on asymptomatic, or are they? Yes, you set it up nicely. But before I go there, I do definitely need to congratulate you and your team for getting to 30 years of very impactful advocacy. I did not realize you started this society when you were 3 years old, but that's we will discuss that at some other time.
Yeah.
Anyway, so the first paper we published, and by the way, yes, Lisa mentioned, and I will reiterate, no industry funding was utilized for either of these studies. All these studies and my research team, they've been funded by generous donors who've given philanthropic support for my research at the Cleveland Clinic. So this is truly basically impactful work without undue external influence, perceived or otherwise. So the first one, it has always been something that I wondered, are these patients really asymptomatic? Okay, let's take them on their word and assume they're asymptomatic. What happens to them if we just collect them and study their natural history? So that was the genesis. From 2002 to 2021, this is the time when electronic records and all that happy stuff was becoming mainstream, right? So we wanted to make sure we were not digging through paper charts and stuff from 50 years ago. So we created a data, my team helped create a database of more than 10,000 HCM patients seen at Cleveland Clinic, and of which we dug through them. Actually, important to say that every chart was reviewed manually. Every chart was reviewed manually to ascertain their NYHA class, including NYHA1. So this is not some computer giving us the data and we just going and analyzing. So it took a lot of effort to create or curate this data. 3,393 patients were identified with HCM who were deemed to be asymptomatic by their history, but also by an experienced physician evaluating these patients at the Cleveland Clinic. So that formed the basis of the population.
So let's pause for just a second
Yes.
for those who are listening who don't know some of our acronyms. So NYHA is what, and how do we use it?
Yeah, NYHA class is New York Heart Association class. It basically gives a physician or a healthcare provider a sense of what the symptomatic status of a patient is. NYHA 1 is your normal, 2 is mild symptoms, 3 is significant symptoms, and 4 is debilitating symptoms. Most NYHA 4 patients would be in the hospital with congestive heart failure, etc. So these were all deemed to be NYHA class 1. Every patient was evaluated at the Cleveland Clinic, and we have a comprehensive program with echo and many cases stress echo, in recent years cardiac MRI, etc. We divided these patients into obstructive as well as non-obstructive based on their gradients on echocardiogram. And a few things we collected along with the standard things we'll talk about, including what happens to their New York Heart Association progression, what happens, how many of them ended up needing septal reduction therapy, how many needed an ICD transplant, how many had an appropriate ICD discharge. We also looked at how many survived in the long term versus not. So if you, Lisa, go on to the table, the baseline characteristics were interesting. After this detailed evaluation, about 4 out of 10 patients, only 4 out of 10 patients had obstructive HCM. So most HCM patients know their numbers. They should know their numbers. What's my wall thickness? What's my gradient? And these patients had a gradient of more than 30 millimeters of mercury at rest or with provocation. Otherwise, the obstructive patients tended to be a little older, more women. They had slightly more hypertension, high blood pressure, and the non-obstructive patients had slightly more family history. So obviously non-obstructive HCM tends to be a mixed bag. So, the burden of making a diagnosis, I find slightly higher in non-obstructive HCM. Similarly, the number of people with defibrillators was slightly higher in the non-obstructive HCM population. And basically, if you look at the echo parameters, again, the walls were slightly thicker in the obstructive arm. The mass was slightly more because they also have to deal with pressure-related obstruction. And as would expect, the gradients and the mitral regurgitation was significantly higher. Their exercise capacity in the obstructive population was significantly lower compared to the non-obstructive. And towards the later part, obviously for more than a decade now, we have started doing MRIs routinely. And so a subset of patients had cardiac MRI, and presence of scar or fibrosis was assessed. And as it turns out, there was no significant difference between the two groups in terms of degree of scar. Now, as we look at these patients in terms of longer term follow-up, what we found during the course of the disease, about 73% remained asymptomatic, but that means 27% did not. 1 in 4 progressed to NYHA class 2 and 2, 3, and 4. So this is real. Just because you are asymptomatic today, you do need to be put into a follow-up plan. The follow-up was long. If you read the paper, 10 and a half years mean follow-up. So a long term of follow-up. During this follow-up, what did we find? 27%, so 926 thereabouts patients died. The mean age was 50 odd years. So, an average follow 10 years. So about 926 patients died. 361 patients underwent surgical myectomy because of the perception of the Cleveland Clinic physicians that they needed septal reduction therapy. 0% mortality in these patients. This is a high volume center. Smaller proportion underwent transplants and even smaller proportion experienced inappropriate deaths. Then if you go to the chart, to the figure, Lisa, this is the money figure. This is what we call survival curves, where we are plotting percentage of survival over the years of follow-up. And the p-value you see is there any significant difference? So anything less than 0.05 of p-value is considered to happen not by chance, but a deliberate event happening. So there are three curves, if you notice. The dotted line is normal United States age and gender match population. The green line is non-obstructive, and the blue line is obstructive HCM patients. So what we found was over the course of time, obstructive HCM patients did worse compared to the other two groups, including the normal US population. When we did some predictors, so what predicts this? Can we look backwards and say what causes this higher mortality? What we found was being a woman was associated with a higher risk. Having a history of atrial fibrillation was associated with a higher risk. And being, as you can see in the figure, obstructive versus non-obstructive, all these were associated with a higher risk of not sudden cardiac death. One thing I forgot to mention in the table is these are asymptomatic individuals, okay? 19%, 9, so 1 in 5 patients had atrial fibrillation. So HCM and atrial fibrillation, it is a complicated love story. They go together, unfortunately. So there is a narrative that, one therapy may cause more AFib than the other. I think what we are living in an era of heightened awareness, heightened detection of AFib. So long story short, what we are able to show in this population is 1 in 5 had a history of atrial fibrillation. Now, one may argue, if they have AFib, how are they asymptomatic? I can show you many examples of patients who do not realize that they have short or long bursts of AFib. When we go and look at Holter monitor or a Zio patch, that's when it becomes evident. And this is why, stroke risk obviously is high and we need to treat these patients. So look, I've given you the punchline here. The important thing is natural history of asymptomatic is not as rosy as one expects, and obstructive folks tend to do worse. AFib tends to be a bad actor. Obviously, every study has to be taken with a grain of salt. We may have missed some outflow tract gradients. Okay, we did not do stress echoes in everybody. This is our data. Our data may not apply to other parts of the country, other parts of the world. And the other important thing, again, New York Heart Association class is highly subjective. And Lisa, and even I will admit, it is provider, patient dependent. It is day-to-day dependent. And of course, this is a clinical population, so genetic testing is not routinely available. Some people say yes, some people say no, etc. But within the confines of these limitations, what we do show is that, in this large, I would say this is the largest natural history study. 1 in 4 patients, asymptomatic patients, progress to a symptomatic state. 40% at face value in this study had obstructive HCM, and we are going to talk about another paper where this number will be slightly higher. And as we incorporate newer therapies, CMIs, cardiac myosin inhibitors, septal reduction therapy, gene therapy, all these things, we have to ask ourselves a question. Should we be thinking about moving the curve of initiation of therapy slightly earlier, especially in obstructive HCM? I'll stop here. We can talk about this paper or discuss at the end after the second paper.
So I'm going to pause for a second because you're bringing up some really interesting points that impact HCM patients every single day. And that is the variability of symptoms and going from a day where you feel asymptomatic to a day where you do not feel asymptomatic. And there's all these places in between where we don't quite know what normal is. I'm going to bring a slide to the stage, which I've shown a few times in different podcasts and different things. We started in about January of 2023 asking patients a different kind of question. And that is, what is your New York Heart Association class? How symptomatic are you on a good day, a bad day, and an average day? And without getting too detailed in here, what we find out is the thing that we know in HCM is that we bounce. We can be in one New York Heart Association class and then bounce to another and bounce to another. So as you can see, a lot of people on a good day are 1s and 2s, but then you start to see on an average day, maybe they're more 2s and 3s. And then on a bad day, they're kind of all over. They're anywhere from a 1 to a 4. And we're seeing people on their good days tell us they're a 1, maybe a 1, 2, and on their bad days, they're a 4. So you can have a lot of good time with your HCM, but you can get hit with a couple of bad days here and there. And trying to figure out what makes you have a bad day versus somebody else is a little tricky. And we're still working on trying to make sense of this a little bit more. But NYHA class is a standardized measurement of symptoms and a burden of disease. And it's really important that patients are very clear with their physicians and their nurses and their teams what they're able to do and what they're not able to do. We have a really bad habit as HCM patients. We're fine. We're always fine. I'm fine because we're used to how we feel, and it's okay because it's not worse. So it's really important to articulate your symptoms or things that you aren't sure are symptoms. I go up a flight of stairs and it's problematic when I go upstairs. Is this normal for my age or is this my HCM? I'm feeling palpitations. I'm feeling this. I'm feeling that. Talk to your team before you assess that you're fine. Look at the details. And if you're not sure, eat a large meal, have a drink, and then try to walk up a flight of stairs and then tell the doc how you felt, because then you've given yourself a little stress test at home that, no, I can't do that anymore, or yes, I'm fine when I do that. And that'll give them a hint as to whether or not there's any obstruction present. So we're going to jump to your second article. So let's talk a little bit, I have hiccups, about the second article.
Yeah. So the second one, if there are some of my patients on this podcast, I've used this line more often than I care to remember. And for me, no or being asymptomatic is a starting point for negotiations. If you are asymptomatic, you're going to have to prove it to me. And I use this line very often. We're going to have the rubber meet the road. Your shoes are going to meet the treadmill. That's the bottom line. So this was a follow-up paper to the first one we presented. And this data was presented at American Heart Association 2025 by Sana Sultana, who is now a resident in New York, by the way. And the first paper was published by Shada, who is a resident here in internal medicine. So these are residents and medical students doing the work with me. So and this is a follow-up study from the same large database we talked about. So again, we know what the data is in symptomatic patients and stress tests and this and that, but what happens, you walk into my clinic and say you are asymptomatic. I'm going to make you run on a treadmill and prove it to me, right? So that was the genesis of the paper. So from the 3,393, about 1,299 patients underwent resting and symptom limited treadmill stress echocardiography. So that's been our practice for many years. We don't, now it is part of our standard HCM protocol that you will be scheduled for a stress echo unless you have contraindications, meaning you're missing a leg or you are symptomatic at rest with very high gradients or something else. Severe aortic stenosis may be there. Other than that, if you are an HCM patient coming to see me or my partners here at the Cleveland Clinic, we will be ordering a treadmill stress echo. So that was the genesis. The data was very similarly collected. So again, everybody was ascertained to be NYHA class 1. Here, in addition to the standard resting echo data, we also collected how much exercise time they had, what was the blood pressure response, what we saw on echo, exercise echo, how much SAM was there, how much gradient, how much degree of mitral regurgitation. Then we went a little further. The exercise time, which we record as metabolic equivalence. I mean, yes, you can also do peak VO2 using cardiopulmonary exercise testing, but we don't mandate that in everybody. It is expensive, inconvenient, and not all. I mean, so we reserve it for some people, but everybody we measure their METs, metabolic equivalence. And what we ended up doing was adjusting the METs for your age and sex. So there are different formulas. So if you're a man, there is a specific formula to calculate what is your expected METs. And if you're a woman, there is another formula to calculate what would be your expected METs. So if Lisa Salberg is coming here for her stress echo, I would know that Lisa at 33 years of age, we established that she's 33 years today. 33 years of age, she should run, let's say, based on her age, let's say she should run 10 METs or 10 minutes. If she runs 11 minutes, then, her age, sex predicted metabolic equivalent percentage would be 110%. But if she only runs 70%, that's lower than what would be expected. So every patient, we calculated this. And of course, the endpoints were similar to the prior study. So if you go to the table, what we found, again, we divided the patients into obstructive and non-obstructive patients. What we found was the age was very similar. Of course, the patient AFib, the amount of AFib was also similar. Background therapy, so beta blockers, calcium blockers, all that happy stuff was significantly higher in obstructive because they are obstructive and we are trying to help with their symptoms. This is on resting echo, right? And importantly, then what we found, if you just relied on resting echo, only 36% of these patients would be characterized as obstructive HCM. So only 463 out of the 1299. But if you put them on the treadmill and then measure their gradients, we found additional 22%. So 1 in 5, little over 1 in 5 patients did not have demonstrable obstructive gradient at rest. We found what the literature calls latent LVOT obstruction. So then when you add the math, that now almost 60% patients become obstructive. So if you are going to a practice and your doctor is not doing all the diligent things to provoke a gradient, including stress echo, you may have a false sense of security. Now on treadmill, and if you look at the table, the lower part of the table, of course, the obstructive patients had far worse, significantly lower exercise capacity. A lot more patients did not achieve more than 85% of age, gender predicted METs. Their gradients were much higher, obviously. Their mitral regurgitation was much higher. And there's a thing that is listed E over E prime. That's a marker of stiffness of the heart, diastolic dysfunction. That was worse in an obstructive population compared to non-obstructive populations. Now, the punchline, these patients had little over 12 years of follow-up, so long-term follow-up. Okay, similar to the other study, 77% remained in NYHA class 1 over the duration, while the rest progressed over time. And within the obstructive HCM population, that eventually some of them became symptomatic, and 28% of that, so 207 patients underwent myectomy with excellent results. But I told you a lot more patients were asymptomatic and obstructive. So based on the prevalent guidelines and the understanding over the time, the physicians at the Cleveland Clinic chose not to send these patients for an operation. So contrary to popular belief, not everybody that comes to Cleveland Clinic gets an operation. We do manage patients without an operation sometimes, but that's something we need to discuss. So now these curves are, again, survival curves over time. So look at the curve on the left. That is dividing the patients into two groups. One who achieved 85% of their capacity and ones who did not. The ones who did, meaning the ones who did longer on the treadmill, their outcomes, the green line, is much better than the ones who did not achieve over the long. So the curves separate. What caught my attention more than anything else was the graph in C. These are three different types of groups. We divide them into three different groups. The blue is non-obstructive HCM. The green is obstructive HCM who had a myectomy. And the yellow is obstructive HCM who we chose to follow who did not have a myectomy. Look at the yellowish line. Their longer-term outcomes are significantly worse. And this is not, we are not talking about heart failure, we are not talking about soft endpoints. These are dead people and non-dead people. Okay, so these are hard endpoints. So this caught my attention. Again, what were the factors associated along with obstructive that did not get operated? AFib, again, emerged as a bad actor. And the other is reduced exercise capacity was another bad actor. Now, we did some additional age, gender-related survival analysis, and what we found was the survival up to 20 years in the non-obstructive and the operated patient was similar to a normal age gender matched population, whereas the survival in the ones that did not get operated was not as good. Look, there are far worse diseases that kill people, but here, compared to the myectomy population, the ones who did not have a myectomy and were obstructive did far worse. Obviously, this is a single-centered study. It is thought-provoking, but the data is data. I mean, this is what it is. So bottom line is, from my perspective, the biggest take-home messages from this paper is, despite a self-described and a physician-ascertained asymptomatic stage, NYHA class 1, a third of the patients did not achieve their more than 85% of age-sex predicted METs. Maybe some of it is deconditioning because your doctor told you not to exercise. Maybe it's the obesity and other risk factors. Maybe it's the beta blockers. Be it as it may, if you did not achieve the exercise capacity, your outcomes were worse. Second important thing was 1 in 5 patients had latent obstruction. So treadmill not only helps prognosticate, but it also helps refine the diagnosis of obstructive HCM. And in addition to that, it provides prognostic value. So the totality of taking these two papers together, the way I think about it is asymptomatic ain't as asymptomatic as we all make it out to be. Use whatever means necessary to prove that you are asymptomatic. And in trying to prove that you're asymptomatic, you may stumble upon a sizable proportion of patients who are not as asymptomatic or who have findings that are contrary to what their perception is. And once you identify those patients, perhaps put them on an earlier train to action, especially in the modern era of highly highly effective medical therapies as well as septal reduction therapy procedures. I'll stop here. Thank you very much.
Thank you for walking us through both of these papers. I think some of it is validating some previous suspicions and some other articles that were out there. I can't help but notice that your one of your references was one of the papers out of Mayo, where they were looking at very similar things. So it's really helpful for patients to know that it didn't just happen in one institution. It's been mirrored in multiple institutions that have high volume HCM centers. And now we are really nailing down what is really the proper way to evaluate obstructed versus non-obstructed, symptomatic versus asymptomatic. I find it really interesting that I go back to some of my very old medical records that are more than 33 years old. And it says that I'm asymptomatic, and I'm laughing going, I've never been asymptomatic since my diagnosis, but I didn't know what symptoms were. I didn't know I wasn't supposed to feel chest pain. I didn't know I was supposed to not feel my heart beating all the time. I thought that was normal. So understanding that a normal person, and I can say this is somebody with a transplanted heart, which is as close to normal as I'm ever going to get, you don't feel your heart beating every day. That's not normal, people. If you're feeling palpitations a lot, that's part of your HCM, or it could be something else relating those palpitations. But I used to hear my heartbeat at night because it was pumping so hard I could hear it all the time. That's not normal either. I did not know that.
The conversation continues, but first, this quick break. We know life with HCM can feel complicated, and sometimes it's hard to know where to begin. The good news is we do. It starts with an intake call with our staff, where we listen and learn about your concerns. From there, we help connect you with our navigation team, who can answer questions about your condition and help you prepare for conversations with your HCM specialist. Intake and navigation help you make the most of every appointment. Learn more about our intake and navigation services at 4hcm.org. Once again, here's host Lisa Salberg.
Knowing what normal and not normal is helpful as a starting point, and pushing yourself with your team to evaluate deeper. 1 in 5 who think they're non-obstructed are not non-obstructed. And if you're obstructed, you have treatment options that you may not be thinking about yet. You might be able to use new medications. You might be a surgical candidate. You might have other options. So I really think it's critical that we have conversations about this, that when you're seeing your doctor, that you are writing your questions in advance and you're saying, this is what I can and can't do. I'm feeling this and that. Is this my HCM or not? There are other symptoms that are a bit more subtle that we probably don't talk about as much as we should. And that's some of the cognitive stuff. And do you get brain fog? Is it from your medication? Is it from your HCM? Is your cognitive capacity what you think it should be? Or is it challenged a little bit because we're maybe not getting proper oxygen to our brains at all times? So we really need to think about all of these things and talk to our clinicians about them.
And Lisa, one comment I'm going to make before I forget. The 1 in 5 number latent, yes, it is important, but it is also important not just to run away with that soundbite, because these were all asymptomatic. So an asymptomatic person, 1 in 5 had latent obstruction. But if you're symptomatic, that's a whole different ball of wax. Correct. And if you're symptomatic and your physician tells you, oh, you have no gradient, So unless the rubber of your shoes has met the treadmill or an upright bike or what have you, as long as you do not have any contraindication, you should not take that for an answer. It's as simple as that. So, my suspicion is if you look at the latent obstruction business in symptomatic obstructive patients, I bet you that number is even higher.
Absolutely. I would guess that you are correct. And maybe as the HCMA patient registry gets everybody consented, you'll be getting phone calls soon if you're in our registry to be in our prospective patient registry that is now IRB approved. So maybe we'll learn a little bit more as well, and we'll be able to share that with our partners and get that published. And maybe we'll get a better understanding of the HCM patient experience with a different lens. So I'm happy to take questions. We do have one from Ross, which is a little it's connected, but it's not connected. He's wondering what factors contribute to high pressures that lead to atrial remodeling and atrial fibrillation. Is there anything on the horizon for our folks who are suffering with atrial fibrillation?
So
how'd they get there, though?
Thanks, Ross. So, few things. One is the HCM itself, hypertrophic cardiomyopathy, diastolic dysfunction, stiff heart. So if the left ventricle is stiff, where is it going to transmit that pressure? It's kind of like if somebody is mad at somebody, you're going to pass it on to the unsuspecting, meeker person next to you. So what is the meeker person next to the left ventricle? It's not the aorta, because it comes with its own punch, right? So it's going to go into the left atrium. So the left atrium is that reservoir which tolerates a lot of abuse from the left ventricle when it is under stress. So that's number one. So what adds undue stress to the LV besides the stiffness is the obstruction, right? So there are two things. Then comes the third thing, which is the mitral regurgitation. So there's three things simultaneously happening potentially in an obstructive HCM patient: obstruction, stiffness, diastolic dysfunction, and mitral regurgitation, which puts undue burden on the left atrium. It stretches, and beyond a point, along comes atrial fibrillation. So I think, and so that's one. What are the things in the horizon? Well, there's a lot of things happening, right? In medical therapy has not really been panned out well. There's lots and lots of emerging data that radiofrequency ablation, now we have the PFA, all kinds of stuff that is happening in the electrophysiology space that is associated with improved freedom from AFib. Of course, if you are somebody who ends up getting surgery, then the surgical PVI or pulmonary vein isolation or the Maze procedure, these are some of the things that can give you freedom from AFib. An important, absolutely important thing that can really impact your quality of life is if you have AFib on HCM, you need to be on a blood thinner. There is no song and dance about that. In fact, I'm aggressive and looking for AFib in these patients. If I find it, there's no conversation. You should be on a blood thinner. People talk about Chad's VAS score in other forms. It does not work in AFib. And if you're going for surgery, then surgeons will clip or chop off your left atrial appendage where most of the clots happen.
Chop off?
Ligate or excise. That's a nice word. Ligate or excise. Okay, we'll be nice about it.
Okay. That was a harsh one.
The electrophysiologist can do something called a Watchman or a LA occluder device. Watchman being one of them. There's a few others available. So management of AFib strategy has also evolved. But what can you, the patient, do? Work on the risk factors. What are the risk factors for AFib? Obesity, big time. Sleep apnea, big time. Alcohol intake, big time. What I tell my patients is, I don't drink alcohol, but I'm not going to tell you how to run your life. But 0 is better than 1 drink, and 1 drink is better than anything more than 1 drink. That's a standard line I use with my patients. So if you can avoid alcohol, by all means do so, because that's a major trigger for AFib.
Yeah. Absolutely is. So I'm going to sidebar a conversation with you that we did not prepare in advance, but I'm working on a very tiny little project here at the HCMA. And while I have you here, and you mentioned AFib and you mentioned anticoagulation. So we're working with a very small startup company that's creating a device to measure coagulation rates in DOAC patients. So that's Eliquis, Perdexa, Xarelto, not warfarin. Warfarin we can measure, but there's no way to measure DOAC. So the person who created the antidote for DOACs has now created a small machine. It's little bit bigger than a cell phone, that you put a drop of blood in, and it measures the amount of time that it takes to coagulate. When I say this is a small study, this is a small study, and we're working on it here out of our office in Denville, New Jersey, with a local doctor. If anybody in the Morris County, Sussex County area of New Jersey is interested in coming out and doing a trial in a doctor's office, it'll take you an hour and they'll pay you for your time. Call the office and we can tell you more about it. We're trying to get some other sites started in Long Island and in New York State so that we can at least test the concept, because it looks like it could really work. And now that I've given that setup, Milind, why is it really important to know if somebody's anticoagulated or not? Should they show up to the emergency room? And when can you give them therapies if they are on a DOAC?
Yeah. So, yes, look, if you come to an emergency room with AFib, and if you use the dreaded word or appear wishy-washy about your diligence in taking your anticoagulation. So DOAC, meaning the newer generation, the NOACs or these kind of drugs. If you say I've missed one dose in the last couple of weeks, and you may not even have, you bought yourself a transesophageal echocardiogram. And before, we are going to look for a clot. If there is no clot, then we could shock you out of it. If there's a clot, then obviously we would not, because that would increase the risk of a stroke. So always take your medications. It's easier sort of with warfarin because we can measure the INR. And if it is therapeutic between 2 and 3, then it is okay to proceed with a cardioversion. But with DOACs, because there's, like Lisa mentioned, there's no specific spot blood check. The assumption is if you take this diligently, if I give you DOAC for a month and you don't miss a single dose, vast majority of the times, we can cardiovert you without repeating a transesophageal echo. So it is important, A, to be taking the medicine, but B, to recognize that there is a potential gap in our ability to make a conclusive diagnosis, and innovations like these is what makes it fun for us and safe for you, the patient.
The other issue that isn't common for HCM, but it is presenting with a stroke while you're on a DOAC, and they can't give you TPA if the DOAC is at a higher dose. You got to let that dose come down. So it's really important to develop this type of technology to keep patients safe and deliver therapies in a more efficient manner. So I'm going to put a post out on this later on, but it's just a tiny baby study. We only need a handful of people. We need a vial of blood and an hour of your time in Denville, New Jersey right now. The clinic is taking patients on Thursdays, noon to 3 right now. We're looking for some more spots. It's very limited. But when we get there, I just think it's a cool piece of technology that we really could use. And we don't normally get involved very, very early in process, but this is, people in the industry and they're like, we got to get this tested, but it's a small company. So anybody interested, please give us a call. Okay, so Milind, non-obstructed HCM, asymptomatic HCM, obstructive HCM, they can all confuse us. Why is it really important to know which one you're in? I want to hear it from you, whether you're really asymptomatic or really not obstructed.
Yeah, look, I think it is important. If you are asymptomatic, then prove it to me, right? Because look, you proving it to me may or may not do anything to me, but it sure as heck will help me make an informed decision that will help you. What does a patient want? Most of them, I want to live longer. I want to live a healthy life, and I want to have a good quality of life, or to the best of my abilities. So knowledge of your symptoms, proven, ascertained knowledge of symptoms or lack thereof is extremely important for us to do our job, and us meaning you, me, and the patient to have an informed decision and a good endpoint. Now, the second question is obstructive, non-obstructive. Yes, right now we have solid, good therapies. We can argue about which drug versus what drug. But, right now it's sort of like we have SRT that is top notch. We have CMIs that have proven incremental value in terms of symptoms quality. Yes, CMIs have not been proven to help improve survival yet, but they haven't been around a long time. So think about it. Right now, we are living in a renaissance age of HCM. Right now, what we have, what did we have for the last 60 years? We had a horse buggy. Now we have, not only do we have a car, but we may have a BMW and a Mercedes. So rather than trying to figure out, is BMW better or Mercedes? No, you got a BMW. Before that, all you had was a horse buggy. Not that there's anything wrong with the horse buggy, right? So, and that is without talking about surgery. And surgery is still excellent. And even, look, here's what I think. Rising tide floats all boats.
Exactly.
Right? And
exactly.
Now in the current era, we are improving, we are identifying more patients, we are refining our ability to make an accurate diagnosis, we have refined therapies. Now there's refinements happening in the field of surgery, alcohol ablation. So I think no matter how you look at HCM, everywhere you go, there is refinement. I mean, gene therapy, we talked about it not
a week ago.
Yeah. A week ago. I mean, Look, right now we are going through the growing pains, obviously, learning it, but imagine a state when, Lisa is not 33 anymore, and I'm not 25 anymore. Imagine a state 25 years from now where we could potentially, if everything is worked out, somebody could walk in for an infusion, go out, do a little immunosuppression, and we've slowed the progression of disease or halted it. If that's going to work out or not, I don't know, but we are hopeful.
I think we are at one of the most exciting times that I can think of in the past 30 years with development. There are more drugs being developed. There's going to be some new clinical trials coming out. For those of you with non-obstructive HCM, there's going to be a survey sent out to you later today. If you're on our mailing list, it'll be on our social media feeds as well. If you're non-obstructed and you want to participate in the clinical trial, we have the Embryo trial, which is, oh God, I got to pronounce it again. Ninirfaxstat.
I just call it Nina. Yes,
Ninirfaxstat, which I hope gets a better brand name if we get to a brand that's easier to pronounce. But this works on cardioenergetics. It works on ATP utilization, and it really gets down to the energy your heart creates and how we do this. But this definitely, it is definitely a HCM renaissance. And it took a long time to get here. And you don't get here because one person does some research. That's a starting point. And we thank those early pioneers for getting us to where we are. But today we are in the situation where there's a lot of really smart people in our field. There's a lot of innovation and things are moving very quickly. I caution you to go slow and think things out, to always have a plan ready, and to stay in touch with the updated data. Like, we have new articles all the time, and that's what we're trying to do here on this part of the podcast, is bring you recent publications so there's not a delay between the data coming out and it getting actually to the patients who need to use this information to make decisions off of. Your clinicians have access to it faster than you do. So we're just trying to balance a playing field that you're right on the cutting edge with them. So stick with us through these podcasts. You'll continue to learn more. If you're not involved with us deeper yet as a patient, please do call for an intake and navigation call so we can start building the path with you and for you. And then you can learn about clinical trials through other mechanisms that we can then send you through emails, through text messages. When things come up, you'll know. And you can come visit us when you want. You don't have to live in your HCM diagnosis all the time, but if we're in connection, you'll know when there's information that might be relevant to you. Okay, well, we have a quiet crew at the end of the month. Not a lot of questions today. And Milind, we've taken a bit of your time and we're going to say thank you. But just a heads up at the end of the podcast. Number one, it's almost February. Number two, The last Wednesday of February is HCM Awareness Day. So I encourage you all to come up with something to do to recognize the day, whether it's memorializing somebody who you've lost or celebrating your wins living with HCM. We do have a couple of box kits ready for what we call house parties. They're going out to our centers of excellence and some of our sponsors. But these posters that are on the wall behind me, you can get by contacting the office. We only have 30 kits to go out. So email support@4hcm.org really quickly, because I think they're going to go pretty fast. I don't even know if we still have 30 left or not, but you get the posters, you get some little tent cards for tables that you can put out at your desk, and no HCM, and there's great codes there. And we have fun little HCM bracelets and other stuff in the box. So order your box. Let us know what you want to do, and stay tuned through the month of February, where we will be doing multiple legislative briefings. And if you are in the New Jersey area and you want to come join us in person for our open house on HCM Awareness Day, the staff would love to talk to you and show you all the wonderful things we're working on. And then on the 25th in the evening at 7 o'clock, I'll be having a webinar, and we're going to be covering all things HCM that are new and exciting. And I'm working on some interesting guests to come and talk to you. So stay tuned for more information. All right, ladies and gentlemen, it is a wrap on the first month of this year. I hope you all stay safe, stay involved, not only with the HCM community, but with your greater communities. There's a lot going on out in the world today, and I know it's a little overwhelming lately. So take care of yourselves, take care of your community members, and know that we're here to support you and your family. No matter what's going on in the world, we're here to support your big hearts. Thank you so much for joining us, Dr. Desai, and thanks for the great work of you and your team on these great articles.
Thank you very much for having me.
The Hypertrophic Cardiomyopathy Association would like to thank our sponsors, Cytokinetics, Bristol Myers Squibb, and Edgewise Therapeutics.